So we are Group 18, and our intervention is called A Rationale for the Elderly, a program to enhance the health of the elderly homeless population.
Our target population consists of elderly homeless individuals living in downtown San Diego who are the age of 55 and older. By 2020, the elderly homeless population will increase by 33%, which is said to double by 2050. We have constructed an intervention program known as C.O.P.E, which stands for Community Outreach Program for the Elderly, in which it consists of a community health center where elderly homeless individuals will be able to gain more resources to acknowledge services that they are easily accessible to. Our main goal is to increase the knowledge of elderly homeless individuals ages 55 and older of healthcare and assistance services in San Diego. C.O.P.E.'s objectives: by the end of the intervention, 40% of elderly homeless individuals in San Diego will be aware of healthcare-related sources. After 6 months of implementing our program, 25% of elderly homeless individuals will utilize healthcare and assistance programs in San Diego. After 1 year post-intervention follow-up, the percentage of healthcare assistance will increase by 30% within the elderly homeless individuals in San Diego community. In addition, this means that for every person that seeks help through C.O.P.E, we would like them to utilize one service that they did not have access to before, whether it's regarding housing, social security, basic medical care, etc. We would like to increase their accessibility to healthcare services they are entitled to.
The model we will be using is the health belief model. This model is used to explain and predict health-related behaviors in regard to the uptake of health services. This is where participants' behavioral actions are influenced by perceived severity, perceived susceptibility, perceived benefits, perceived barriers, cues to action, and self-efficacy. These are a series of responses to each theoretical construct of the model. Our mission is to show the elderly homeless individuals that with C.O.P.E we can break down these barriers and present them with services that they are entitled to.
So our outcomes will be measured primarily by surveys. We'll do questionnaires before the intervention to find out what services are currently being utilized, if any. We'll be doing pre-test, post-test surveys. We'll have both qualitative and quantitative results. Our quantitative results will be how many people are using our service and how many people are accessing services. We'll have qualitative data we'll be asking about their background to find out what services they qualify for. We'll also be trying to identify any barriers that they might feel exist that are keeping them from accessing services. Our level of measurement will be a ratio. There's an absolute 0, meaning 0 people could be using our services, although hopefully we will increase that. We have a non-experimental design because we don't have a comparison or a control group. The goal of our intervention is to assist as many participants as possible in accessing services, so we don't have a control group. We will have a limited budget. We also will have a time series design. So for our experimental group, we will have an observation, we'll have our intervention, and then we'll have multiple follow-up observations after that to find out how our program is going and if it's making a difference. There are some limitations to not having a comparison or control group. It will be more difficult for us to determine whether or not our intervention is actually making a difference. Although again, the main goal is to help as many people as possible, so we again decided against a experimental design. In conclusion, our population is homeless but not hopeless. While we do aim to establish connections to resources, it's not just about providing services. It's about eliminating barriers and giving individuals the self-efficacy they need to change their health behaviors.